Well, first off, thank you very much for inviting me to join you this evening. It's a distinct pleasure and honor. I especially want to thank my good colleague and friend, Dr. Narasimhan, and so many distinguished scientists and clinicians who have contributed such a great deal to the field of blood pressure and non-communicable diseases in general here tonight. So I'm going to talk a little bit about trials, guidelines, and improving blood pressure control and what I think is the way forward. And I'm glad to be here in my role as president of the World Hypertension League. So I'll start by saying the obvious. As you well know, blood pressure is strikingly related to many outcomes: stroke, ischemic heart disease, heart failure, dementia, many others. And we see that at all ages. We see it in men and women, systolic, diastolic blood pressure. The relative relationship of risk is stronger in young people because you usually see elevated blood pressures as an isolated risk factor. The slope is a little less steep in older age because there are many risk factors at play, but of course the absolute risk for the patient is much greater. And we see this pattern now. It's been reported from a systolic of 90 millimeters of mercury all the way up to greater than 180 millimeters of mercury. So while we talk in our classification systems about normal blood pressure, the true biological normal blood pressure is much lower than what we put in those classifications. And if you're thinking about preventing the very early phase of atherosclerosis, fatty deposits and plaques, probably the body would be much happier with a systolic blood pressure that is much lower than we think about in clinical practice. So high blood pressure, however you define it, is extremely common. And I put two definitions here, looking at a systolic of 110 to 115 or greater, and what many clinicians have used over the years as a definition of hypertension, 140 or greater systolic. I should say, incidentally, classification systems for blood pressure have changed dramatically over the years. There are no hypertension receptors in the body. The body responds to blood pressure. And getting an estimate of usual level of blood pressure through accurate and precise measures of blood pressure, doing it properly and getting an average of readings at more than one observation is really what we need. But even if you take the 140 and above, there's a huge burden of illness from ischemic heart disease, stroke, and hemorrhagic stroke. And if you look at disability resulting from it rather than deaths, it becomes even larger. Most of the events are ischemic heart disease, but stroke is not far behind. India is the epicenter for the burden of illness due to high blood pressure. India and China are the two biggest contributors because of the size of the population. And as your population gets older, you know you're going to have an even bigger problem from non-communicable diseases. Dr. Narasimhan gave a very nice presentation on prevention of high blood pressure or non-pharmacological approaches, which can be used to prevent or to treat. I spent much of my early career doing trials around trying to understand what would prevent high blood pressure. And in our US guidelines, based on a very rigorous interpretation of the clinical trial information, we concluded that weight loss, a healthy diet, also all healthy diets, Mediterranean diets, the DASH diet, any healthy diet will lower blood pressure. Dietary sodium reduction, dietary potassium, as Dr. Narasimhan said, preferably through diet. Physical activity, best proven for aerobic exercise, but for all types of physical activity, and moderation or abstinence from alcohol. all of these work. And in individuals who have pre-existing hypertension, you're going to get, if applied properly, about a 5 millimeter reduction in systolic. And for those who don't have hypertension, usually get about a 3 millimeter reduction. You can prevent the onset of hypertension. And prevention is always better than treatment. But in addition to prevention, obviously, diagnosis and treatment of hypertension is helpful, and we have a plethora of randomized controlled trials. I show here a pooling or a meta-analysis of 123 randomized controlled trials, and you can see for all the major cardiovascular outcomes, there's benefit. We don't see benefit here for our renal disease, and that's largely because people with kidney disease were not entered into these trials, but we do see it in the kidney trials. And if we look at those trials, you get the same relative benefit for reduction of risk in those with pre-existing cardiovascular disease or without. You see the same benefit for people who enter those trials with most levels of blood pressure, certainly 130 millimeters of mercury and above. And you see that in several different meta-analyses. And the question always comes up, of course, and was an important question at one time, does it really matter which drug is used? And I think the best trial to address that is one that I chaired. It's called the Antihypertensive and Lipid Lowering to Prevent Heart Attack trial, or ALLHAT. It was a large trial with 42,500 adults, 55 years of older, and with additional indications for cardiovascular risk. And what was unusual about this trial is it was not commercially sponsored, and we were very careful to select 3 agents that represented the leading classes of antihypertensive therapy. Chlorthalidone for the diuretics, amlodipine as a representative of CCBs, and lisinopril as a representative of ACE inhibitors. And we selected doses that were comparable for the 3 of them. It was double-blinded. The second step therapies and the third step therapies were identical. The resulting therapy is not what we would typically use in clinical practice, but it allowed for a very careful comparison of the first step agents. And the primary outcome in this trial was to determine whether there was a superiority for using the CCB or the ACE compared to the diuretic for prevention of coronary heart disease. And when we finished the study, there was essentially no difference for coronary heart disease, the primary outcome. There was no difference for all-cause mortality. There was a slight difference for stroke. The ACE inhibitor was not quite as good as the diuretic, and we've seen that in several trials. It's not dramatic, but it's there. And a very big difference in heart failure. And that's a very common finding, especially for a diuretic compared to a calcium channel blocker. We also saw that to a lesser extent, but highly significant for the comparison with an ACE inhibitor. So I think that's the most careful comparison of first step therapy. But we have a lot of other trials, and when you pool those trials, what you see is most of the first step agents are pretty similar in terms of benefit, telling you that really the driving force here is reducing blood pressure. Beta blockers are not as good as the other first step agents. They're definitely better than placebo in placebo comparisons, but not as good as the other agents, primarily because they're not particularly good at preventing stroke. So most guidelines, and certainly the US guidelines for many years, has said, don't use beta blockers as initial therapy for treating hypertension unless there's a compelling indication. This is another meta-analysis just to show the same sort of thing. Here we're looking at the particular drug on the top, the outcomes on the side. Green is better, red is worse, yellow is the same. You'll see for beta blockers, again, a consistent finding that compared to the other agents, they're not as good for prevention of stroke. But they're red in a number of other areas. Again, for calcium channel blockers, you'll see a lot of red around heart failure, not very good for preventing heart failure. The best in class of these agents is really the diuretics, where you won't see any red. So you don't have to use a diuretic, but I think having a diuretic in the mix is very sensible. We used to, in the US, suggest diuretics as the initial therapy. We relaxed that in the 2017 guideline and said, use either of the 4 classes of agents, diuretics, CCB, ACE, or R, because they're all pretty good. And in reality, you're going to be using combinations of those agents anyway. We know from lots of trials that it's very unusual to control an individual on a single antihypertensive agent. And the trials that have aimed for a systolic less than 140 and a diastolic less than 90, typically we've required an average of 2 medications. For the trials that have targeted less than 120 millimeters of mercury, we've typically required a mean of 3 medications. Here's the pattern for all HAD. You'll see for using a single antihypertensive agent, we controlled a little under 30%. For 1 or 2 agents, we controlled a little over half the patients. And then as you added in additional drug, you got better control. The combinations are very logical. A use of drugs that complement the physiologic actions of each other. So generally a diuretic or a CCB with an ACE or an ARB would be the sensible starting point. And if using 3 drugs, a diuretic, and I would say preferably a long-acting diuretic like chlorthalidone or indapamide, with a CCB or an ACE or an ARB, make good sense. It makes good sense to use these drugs where it's feasible and it's financially prudent as single pill combinations. But again, when we wrote our guidelines in the US, we said we recommend single pill combinations. They are good, but we were a little cautious because at the time we wrote that guideline, single pill combinations tended to be more expensive than prescribing the 2 drugs separately. And for many of our patients, they can't afford that additional cost. And we also were a little concerned that the diuretic dosage in many of the combinations was very low. And it may be adequate, but there are no clinical trials for cardiovascular prevention that have shown benefit with diuretics at the doses that you see in many of the combination therapies. So the next question, of course, is how low to go. And when we're looking at this, typically 3 types of trials have been looked at. Blood pressure differences in drug versus placebo, more versus drug therapy. And the best of all is looking at trials that have randomized people to different blood pressure targets. And I show here a meta-analysis from our group. And this is a network meta-analysis, which gives you a lot of statistical power. And basically, what we're able to show in these sorts of meta-analysis is that lower is always better than a higher achieved blood pressure. And the bigger the difference in blood pressure, in other words, the higher the starting level of blood pressure, getting to that lower level, the more beneficial impact the patient is going to see. But even for small differences in blood pressure, you're going to see beneficial impact. And you see it not only for major cardiovascular disease events, as I'm showing in the figure, but for all the individual components: stroke, coronary heart disease, all-cause mortality. Excuse my cough, I have a post-COVID syndrome. It doesn't really matter which trials you include or exclude, and this pattern has been reported by many different authors. Now, the best trials, of course, are the trials that have randomized to two different, I have water here. It helps sometimes, but not all the time. The best trials are really the trials that have compared people randomized to different levels of blood pressure. And what we've been looking at most recently, most carefully, is less than 120. There's abundant evidence that getting to less than 130 systolic is beneficial as long as it's tolerated. So we currently have 4 trials that have reported on less than 120 versus less than 140 systolic. And they're all showing the same pattern. Accord BP in diabetics, Sprint, where we included a lot of older people and people with kidney disease, Respect, which was a stroke secondary prevention trial, and a Spirit, which was recently presented at the American Heart from China. They all show a pattern that suggests getting to less than 120 millimeters of mercury is better than 140. There are 3 additional big trials in progress, 2 in Brazil, the optimal BP trial in diabetics and the optimal BP trial in stroke survivors, and another big trial in China. So we'll soon have 7 trials, and I think we'll have pretty definitive evidence, but I think what we have now would suggest that what we see observationally is what we get when we do the clinical trials. Getting to lower pressures always seems to be better as long as the patient's tolerated. And in these trials, there have been remarkably few complications. There are some electrolyte abnormalities, as you would expect with using more drug. So it's 3 drugs on average in the intensive arm versus 2 in the non-intensive arm. And there's been a slight average decrease in estimated GFR, about 2 to 3 millimeters of 2 to 3 mils per minute per 1.73 meters squared. It's not huge, and it's probably a hemodynamic effect. It seems to reverse itself if you stop the intensive treatment. And at this point, we don't really know whether that is going to be beneficial for kidney protection in the long term or whether it's detrimental. But it doesn't seem to be a big negative in comparison to the positives, which are very dramatic. Major cardiovascular disease prevention, major prevention of all-cause mortality. In the most recent trial from China, the rural hypertension trial, a definitive 15% reduction in dementia events. So these are all very dramatic benefits from getting to lower pressures. The guidelines are fairly consistent. If one looks at what is recommended for a clinical practice setting, in clinical practice, almost always one sees a high cardiovascular risk because patients who come to us for care usually have multiple risk factors. They're often older and they have overweight, and they have diabetes, and they often have lipid abnormalities in addition to blood pressure. So typically in clinical practice, it's going to be high risk, and there are guidelines. They vary from suggesting less than 120 to about less than 135. It's a little different in public health practice, but what do we see in practice? Well, we saw what was happening in India, and what's happening in India, sadly, is what's happening all around the world. We're not doing well anywhere. In the US, where we had some of the best control rates, we've slipped in the last decade or 2. In Canada, which was even slightly better than the US, they've slipped also. And in other countries, the situation is far more precarious. Our group has been looking at global estimates of high blood pressure, hypertension for a number of years. We published in 2000, 2010, and we're likely to publish in the next year on an update. There was a slight improvement between 2000 and 2010 in the high-income countries, but it got worse in low-income countries like India. And overall, in low-income countries, the control rates, even at 140/90, were less than 8%. So that's very sad, because here we have a disorder that we know how to treat, we know how to control it. It's just not happening in practice. And you might say, why is there this big disconnect between what science is telling us and what's happening in practice? And I would say I'm old enough that I've seen this picture many times. And I've seen it most recently in the SPRINT trial, which I chaired. And what happened in SPRINT is during the time we were intensively treating patients, they derived great benefit. Their hazard ratio for cardiovascular complications went way down. And then the trial was stopped because there was significant benefit in the intensively treated arm. And we were instructed to stop instructing the primary care physicians. And there was a period of time when we started to withdraw, and eventually we were completely withdrawn, and that hazard ratio went right back up more or less to where it started. And we think almost all of that is due to blood pressure changes. So we have blood pressure changes in the practice setting from the electronic health records, and you see a big delta or difference in blood pressure here during the period the trial was being conducted. And then as the trial was stopped and we didn't give the advice to clinicians anymore, what didn't happen is the standard care treatment group didn't get treated much more intensively. And what did happen, sadly, was the intensively treated group were allowed to go back in their pressures to more or less where they started. And this tells us a lesson that we've seen with beta blockers and many other interventions, that there are a lot of reasons for clinical decision-making that have nothing to do with science. So we have to go back to the books, because we develop guidelines, but they're being ignored. And we have to really think about how we develop guidelines and how we portray them. And when the World Hypertension League is in official relations with WHO, and we advised them as they were thinking about doing a global study to try to prevent and treat high blood pressure, called the HEARTS study. And what we basically said is we have to incorporate more implementation science into what's happening. So there has to be a commitment by the provider, the institution, or the country, and specific goals. We have to recognize that most patients have very simple, uncomplicated hypertension. They can be managed with simple algorithms. Team care is very helpful and frees up the physician and requires only modest physician oversight and time. Patient engagement and patient-centered care is very important. Access to effective and affordable medications, preferably at the point of care, is essential. And tracking and pace management is important. So that's what we suggested to WHO, and that's what's incorporated into the HEARTS program. And we know that type of model has worked very well. I mentioned the China Rural Community Healthcare Worker Trial, where they used a very simple approach to treating high blood pressure, but it was very well executed. And what they got at the end of the trial was a huge difference in systolic blood pressure, more than a 23 millimeter difference in systolic blood pressure, And that manifested with huge benefits in the primary outcome, a composite of cardiovascular disease, and in the individual components as well, and a huge benefit in all-cause mortality, and a huge benefit in dementia. And we also know this works well in high-income countries, and many systems of care in the US have this type of approach. This is one of them, Kaiser Permanente, but it's also used by the Veterans Administration, by Geisinger, and many other big systems. And in the Kaiser experience here, when they started to implement this multifaceted system of care, they rather quickly went from controlling at the 140/90 at about 40% to about 80%, and later to about 90%. So we know it works well, and I would say in summary, high blood pressure remains a huge personal, social, and economic burden. There's a very strong basis for prevention, diagnosis, and management. There's a huge disconnect between efficacy trials, guideline recommendations, and clinical practice, and we have to do better. And the way forward, I think, is to use a different paradigm that allows for simple, well-executed implementation of team-based care using effective approaches and doing it in a convenient and efficient manner, tracking with immediate case management, and rethinking how we formulate our guidelines so they have maximal impact. So that's, I think, the way forward. There may be better approaches, but clearly we have to do something very different than what we're doing now, because we're not doing things right for our populations. And with that, I thank you again very, very much for inviting me to be here tonight. And of course, like Dr. Narasimhan, I want to invite you and hope you will be a part of the 6th World Hypertension Congress that will be held here in Chennai in 2025.